Anyway, I thought they were so fascinating, those talks. So how can we highlight how screening, worldling diagnostics and genomics can save lives through earlier diagnosis and interventions? Richard, could I start with you?
Yeah, so you've heard a little bit about Genomics England and the generation study. I'll perhaps use that as an example. So I'm Rich Scott, I'm the CEO of Genomics England. I'm also a consultant in genetics at Great Ormond Street. And I think really that the generation study, which is I think a really nice paradigm of how we in the UK are so uniquely placed to address some of these questions. You've heard from Stephen, the scale at which questions can be asked, studies can be run in the NHS, and we at Genomics England, we're a government-owned company, and we have the privilege of working in partnership with the NHS to ask some of these big questions, and it does require sort of the will of our sort of national infrastructure and that investment, but it means that we can ask these big questions looking to the future. So in the generation study, we're saying, can whole genome sequencing, a particular technology, be useful to move that, to make that shift that we've heard about from the Minister, to increasingly from sickness towards preemption and even prevention of rare genetic conditions. Our role is to act as a data and evidence engine, both for the NHS in delivering care, but also in research like this. And it's that link between the two, bringing in whether it's academia, but also life sciences, that is absolutely critical in the success. And I'd say it's partly about moments in time where you can ask a specific question and say, what's the evidence that we can actually make this shift, addressing one particular question. I think one of the other things that there's a real opportunity for here, and we see that through the investment in digital infrastructure, ours, but more broadly in the NHS, is to say, how can we create a system that continues to learn and can say, I've implemented a new intervention. Perhaps I'm in the screening committee and I've made a recommendation. What's the feed of data that I can continue to get to continue to learn about that in the future? How is it working? How can I fine tune it? Is it an intervention that actually I should say isn't working so well? And also, if I'm from the life sciences sector, how can I know that I can continue to generate evidence on interventions that I have, and how can we make that more organic link between routine care and research, which is absolutely critical.
Okay, well, that's fantastic. That's a really good answer. Stuart, Dr. Stuart Adams is the Honorary Associate Professor at UCL and Consultant Clinical Scientist at Great Ormond Street. Would you like to just say a couple of words on these areas?
Yeah, I think it's been really interesting to see the landscape change, I think, over the last 20 years. I started out when gene therapy was first being rolled out as the groundbreaking technology for treating children with some rare diseases. And at that point, we realized we had these wonderfully expensive, elaborate, novel therapies, but they only really worked to great benefit if we were picking children up early, at birth, to treat them most effectively. And that pathway wasn't there. The pathway was there, but it hadn't adopted modern technology and using DNA as biomarkers. And there was a real challenge at the time. It took 15 years or more from inception of an idea to get a pilot program rolled out, which is now just finished and is now in the evaluation stage. And having seen the change and how quickly we are now willing to adopt new technologies into screening programs and diagnostic programs, I think has been something which has got me very excited in this new era. And I'm just hoping that the pathways can keep up with the influx of early diagnostics coming in, and especially in newborns, and the treatment pathways and infrastructure keeping up with that. And I think that's where perhaps our further thought should be as we embrace these new technologies, which undoubtedly are. And it is a really exciting time, I think, to be in the life sciences. I'm certainly enthralled by it.
Yeah, thank you. That's a really fascinating insight. And our other new speaker, Professor Dame Lynn Chitty, the Deputy Director of the National Institute for Health and Care Research at Great Ormond Street. Can I just ask you to say a few words, and then we'll sort of open it up to questions and queries, if that's okay?
Yes, so I'm actually Deputy Director of the BRC, Biomedical Research Centre at Great Ormond Street. which is the NIHR one. I think what's happening with the generation study is great and looking forward, and I think genomics is really exciting. I'm also a professor of genetics and fetal medicine, and actually I think we're beginning to lag behind looking at newborn screening. We need to be thinking now, because it takes a long time, as Stuart has just said, to move this newborn screening to the fetus, and I think that we have the potential for doing that with cell-free DNA. Because many of the conditions that we're treating, that Rich and the generation study is screening for, the damage starts in utero. And in order to ameliorate the damage in utero, we need to be able to treat them in utero. And we are beginning, and there are a number of trials ongoing in the US already to treat some of these conditions. And it does take a long time to get these trials, these screening tests up and running. And it is going to be challenging. But I think we need to be thinking about that now. And I'm sorry Lucy's gone, because I think this is something that the NIHR should be thinking about. And we are certainly in our BRC beginning to do some work on this area, working both with patients and health professionals to take views and ideas, what do they want, but also developing the technology. So I know Rich thinks we should take one step at a time and do the generation study. I think we should be doing these in parallel because we're going to fall behind.
Okay, thank you very much. That's really interesting. Now, I was going to open it up to the floor now.
I understand we can't study anything that we might plausibly want to study. There just isn't enough resource. But why do people use terms like 15 years when talking about setting these things up? And people are going to get sick of these things, be born, get sick of these things, and die before they've even decided to survey. What is the process, Paul?
Would you like to take that one?
Yeah, maybe. Shall I start? Or do you want to?
Well, I was just going to say, I think it's the legislation, the legislative hurdles that you have to jump after you've done the research. I mean, we've got NIPT for aneuploidies, cell-free DNA screening, evaluated and set up and approved. But then there were so many different hurdles that you have to get through: education, the National Screening Committee, NICE, all of those things.
I would say I think there are important figures to quote. I would also think that we're not just talking about the future, about this changing, accelerating. I'll point to, in diagnostics, one really great example of the NHS and making decisions at pace. So, for example, Genomics England was set up first to deliver the 100,000 Genomes project. The recruitment to that project finished in 2017. In 2020, the NHS launched a first national whole genome sequencing diagnostic service that Stephen was talking about. That shows that with the right investment, some of it's about how decisions are made. Some of it's also about having the right infrastructure that you can build and make more rapid decisions. So I think part of what we're talking about this evening is that actually the UK, the NHS is uniquely placed to continue through continued investments to be on the front foot and to say, we know historically and in some areas it's still really challenging to make that move at pace, but with the right investments, with the right evidence and adaptable policy and sort of decision-making processes, it really it can be faster, and we can see there are examples of where it is.
But
the investment is key.
Years is quick.
But you need to train people, you need equipment, you need capital investments.
Fine,
It is quite complicated as well. I mean, doing things to change treatment pathways or diagnostic pathways for one disease is one thing. Doing it at population level and the impacts this can have on a wider system is another thing. And I think an anecdotal case would be one of the things we wanted to have newborn screening for had an unforeseen impact on the vaccination program. And therefore, everything got delayed while the vaccination program had to adapt and change. And actually, no one had foreseen it. And sometimes with these big, complex systems, it is necessarily difficult, complicated, and slow. But I do think it doesn't need to be slow. And I think things have changed. And I think the illustration with the generation study is a good one. There's something so far-reaching to get that running in such a short space of time, I think, is incredible.
Okay, thank you. Helen, would you like to come in?
Yeah, thank you. So to your point, I think that research does need a framework of rules to work through. But I think that is one of the possibly the opportunities is to look at the regulatory framework and identify what can be taken out, so that the things that do matter that you've referred to, they can still be undertaken, and bring that down and really take a good look at what rules can be looked at, what can be changed, and what can make that system quicker. Certainly from an industry perspective, that's very important, but also for the patient, and to work within a risk-managed, risk-based regulatory framework to enable us to get through from a technological perspective and be safe for the patients.
Good. And Mike, do you want to comment on that as well?
Yes, I mean, I can assure you we are doing our level best to decrease that interval. One of the ways we're doing that is for the screening committee to work closely with researchers and actually say, is the research going to answer the sort of questions that the screening committee is going to want to have? And we've set up a research and methodology group, and researchers are now working closely with that group. So I said earlier that we have to look at the potential harms of screening, and so are those questions being asked at the time of the research? And that will, again, because what you don't want is to do a research study and then say, oh damn, we haven't actually answered the questions we need. So we are working on that really hard.
I do think that's an excellent challenge, though, because I think there's some bits that we could shorten, and some bits we can't, and we have to identify those bits. So thank you for that. Good question. So yes, on the just behind the previous speaker, if that's okay. Could you just? Okay. Well, yeah. If you could just say your name.
My name's Kevin Garwood. I hear a lot of excitement with respect to screening, both in a sort of genetic screening and also with medical imaging. And one of the things that's starting to come to mind is, how are you managing regulation with respect to medical devices? Because all the stuff you're talking about in terms of making a diagnosis based on sort of technology would seem to me qualified as medical device activities, which brings in its own particular overheads of trying to go and bring that forward. How are you trying to do that at scale when you're trying to scan for ever larger numbers of diseases, or in the case of medical imaging, where you're perhaps relying on emergent aspects of AI to go circle tumors and bits and that?
I think to that point, with everything that's happening with the regulatory framework now, that's certainly something that needs to be pushed and understood. I mentioned in my previous answer about a risk-based process, and I think that is a change in behaviour for the NHS and for the regulatory, the research environment, that we need to all work together, partnership for industry as well as clinicians and academia, so that we can identify what is the safest risk-based environment to do that in. Because if we are successful in our innovation and our research, the regulatory framework won't be able to keep up with us. So we need to make sure that it can support what happens in technology, rather than just be tying people up in red tape.
Just in terms of the imaging side of it, what we have to demonstrate is that the AI is at least as good as the human in interpreting images, and it doesn't necessarily have to be as good as the very best human in the country, because there is variation amongst the humans. But we are already using it. So it's being used, for example, in stroke medicine, where somebody working in A&E can get a quick idea of whether this person is going to be suitable for mechanical thrombectomy. I've heard a neuroradiologist say, I don't think it's as good as I am, but that doesn't matter, because it's the casualty officer that needs to make a decision to send the patient on. I think with skin lesions for possible melanoma, we are also working on AI to interpret images of skin lesions. Breast screening is another area where I'm sure it will come in, but at the moment we are just wanting to make sure it is at least as good. Because with breast screening, we have a rather Rolls-Royce system in this country at the moment. We have 2 humans looking at every mammogram that's done through screening. Now, whether that is sustainable long term, I rather doubt. But while we're moving to that, we need to make sure the AI is as good.
Are you envisioning those people would ultimately defer to the AI algorithms for a gold standard?
Well, let's get to that point if we can, but we need to know how good is the AI, and that's where we need the research, and we're working very closely with NIHR on that at the moment.
Richard, did you want to say something?
Yeah, I guess, I mean, Helen alluded to it as well, but I think the regulator is key here, and actually partnership, and the MHR has shown real appetite for being innovative in various areas, not just from a medical device perspective, and that's really crucial for us. We spend a lot of time, a bit like Mike was discussing, that National Screening Committee being part of the discussion in study design. For us at Genomics England, both working with MHRA and others to say what sort of evidence do you need generated, but also one of our roles is working with life sciences companies who have a diagnostic to say, how can we support you in generating evidence from our data sets that will like provide that evidence that's needed to show the balance of risk is appropriate.
And Helen, do you want to say more?
Yeah, so coming back in, I think out of the shifts, my priority, if I was able to do that and be in charge, my priority would be data, because to your point about the evidence of is it good AI, the more data that can be generated and the more that can be reviewed and the faster that can be, the decisions, it will do two things. It will be available for the decision making for those clinicians, but then it will also start to prove the technology and reduce the risk within that environment in the first place. So we should be investing, we should be looking at making sure that the data, because the NHS has, as we all know, got unique access to that patient data. That is what will make good decisions, and that is what I think we should be looking at doing first.
Okay, that's great. Now, there was a question about, could we take this? Yeah, great. You're next. Fantastic.
Okay, Angela McFarlane, IQVIA, we're a global commercial clinical research organisation. Lynn, it's just not taking exception to what you said, but this business, in answer to the first question about legislation, we recognise legislation is needed, but since 2017, I was saying to UK government, commercial clinical trials are going to fall off the cliff if you don't address these 10 things. And much of it was bureaucratic undergrowth, and it's a shame that Lucy's gone, but anyway, we've had this conversation before. When the COVID urgent public health response, which Peter was referring to, happened, they initiated 6 out of the 10 recommendations without legislation straight away, because they had that one mission approach and we had to do it. And unfortunately, and I know Professor Powers gave a very glowing kind of thing about COVID and how wonderfully we did, we've reverted to business as usual. And we cannot get key metrics for first patient in study in the UK. And that is a real key metric. And, you know, just this week, we've turned away 2 trials that we brought to the UK, and now we can't do them. And this is where the diagnostics plays in. We want to bring in automation and using AI for screening, for finding patients and all of that. And for example, what would take a clinical research associate sitting in a trust or a primary care organisation 30 days to do, through the AI technology we have, we could automate that and get it down to 12 hours and cut out all the, fees, just everything. I've spent 2 years talking about this to the bodies that were represented here tonight. And like this gentleman, I'm bored, I'm tired, and I'm losing hope. So I don't know if in, these new I think you said bored, and we'll all go away. And, they talked about life sciences superpower in the UK. I've been doing that for 7 years now.
So I think
we need urgency.
So we're working on that. And certainly from we as part of our BRC work, we're getting genomic data directly into the EPR so that you can search EPRs and identify patients that you want to do trials on. So we are definitely working on that. And I think the way that the NHS is increasingly being digitised, you should be able to find it. I think one of your hurdles will be R&D and those sorts of hurdles to get past. It's not just finding the patients, it's actually getting the approvals. And I share your pain.
Yeah, make sure I've done a great job there.
Yeah, I share your pain, and I think we really need to do something about that. And the other issue is information governance.
In 2010, we used IQVIA data in your fantastic cancer report to show how we were one of the poorest performing countries in the world for cancer. Sadly, not a lot has changed. And nice technologies take 4 years on average to get up to 80% of the approved cohort that includes diagnostics. And the inequalities by ICS is appalling. And if Andrew was here to hear that, he would be a leading part.
You're absolutely right. I think I said that in 2010. I have to say I'm not responsible for it, but just let me make that clear. But there is lots more we can do.
And anything further to say on that? Okay.
No, I think we should share the
I like the challenge, and I think it's good. That's what it's all about. You try working in politics if you think science is slow. To be honest, it takes even longer to get things. Right, you have right, so you know what it's like.
It is incredibly frustrating for researchers to develop something and then see it take so long. And I've been on that bandwagon for a while.
You don't need to be stabs, but true.
Yeah. Well, thank you for your question. Now there's a question over there. Yeah. Could we get sorry. Okay, I'll come over here and then I'll come to the back there. Can you say your name?
My name is Helen. I'm very interested in early lung cancer diagnosis. I was wondering when the lung cancer screening will rule out nationally and in what format: lung, CT scan, combining with gene test and blood test. And my next question is that because lung cancer at an early stage is manifested as a symptomatic nodule, even highly experienced radiologists find it very challenging to interpret the nature of the nodule. So that is why early diagnosis has been so difficult. So my question here is that because nowadays we have so many technologies, AI and life science and gene, etc. So what technology is available now to fill this gap? Thank you.
Effectively, we are rolling out lung screening. It started as a pilot study, which is called Targeted Lung Health Check, which has been very successful. It's picking up a lot of early stage cancers. I think the last figure I heard was 77% of the cancers that they discover are at stage 1 and 2. And that for lung cancer is really remarkable. Yes, it can be difficult to tell whether a nodule is going to be a cancer or not. But that's why if there are nodules, we get the patients back to have repeat scans. And then if need be, that gets biopsied. So I think we've got international trials that say that lung screening saves lives, and we've got a pilot that is becoming a screening program that is actually working really well.
And I think you need to throw circulated tumour DNA into the mix. So you've got your nodule, do your circulated tumour DNA, and then that'll avoid your biopsies, avoid your bronchoscopies. One of the things that would have to happen is shifting money from one part of the NHS to another part of the NHS. And that is like trying to get pigs flying, I think. So,
there's no money in either side of the NHS. There's no money in either side of the NHS to move from one side.
Oh, okay, whatever. But it's circulated tumour DNA there for breast lumps, for lung lumps, all sorts of stuff.
I agree, and I think diagnosis is so key to screening, and it's going to become more important. I mean, I've talked to some people around prostate cancer screening, and that's all about MRI scans. But my patients have to wait about 8 weeks for an MRI scan.
And we have a huge study of prostate screening just getting underway, the Transform study, and we are looking very seriously at whether there are high-risk groups that could benefit from screening. So we're on it, but again, we have to do it so that we know that the benefits outweigh the harms.
And when we do the screening test, if you implement a screening test, you need to think what the pathway looks like. Have you got the resources and the workforce in particular to do the screening, to do the mastectomies or whatever, once you've identified people who are at risk? Because I don't think that is necessarily in place at the moment.
No, absolutely, that's really important. There's no point diagnosing if you can't
manage it.
Yeah. So this gentleman here, sorry to keep you waiting.
Thank you. James Fisher, responsible for, with the team, delivering 100,000 rare disease and cancer tests for 8.5 million population in the southeast. And to deliver these things, and like you say, Lynn, about circulating tumour DNA, we're just about to launch rapid SMA, and we've also got CYP2C19 for clopidogrel. All these things, we need, yes, money. Helen, I know there isn't much around the system, but it's the short-termism of contracts that prevent the ability to borrow the money needed to purchase the equipment and pump prime this. So when you were talking earlier about how do we accelerate from research, which is brilliant, into practical realities, I become the bottleneck because I can't access the capital funds. But that's my comment, sorry. The quick question is, we're talking about moving from reactive to proactive. The old adage, you can lead a horse to water, you can't make it drink. How are we going to influence the public to engage with this new strategy?
That's a good one. So do you want to say that, Helen?
it's not necessarily a full answer, but certainly some work that we're doing. We're really looking into the behaviour of patients and the public, because I think that is critical. And I think also if some of the funding or the research funding bodies can start to look into behavioural research as part of the overall environment, I think that will be really useful. There are 75 years, and most people's entire lives are used to going to the doctor when they're ill to get fixed. Diagnosis is inherently negative. You go and find out if something is wrong. So it's everything about relearning how to use a health service, because you will otherwise end up with a health service with people still using it incorrectly, or it will be incorrectly at that point. I don't think you can just look within the health service. I think you need to look at how are you going to teach people to use it, and how are you going to pull that through. And it is absolutely critical, as well as the technical research and the funding from those areas.
So it's a sort of public shift in perception. Yeah, very profound. Mike?
We're constantly looking at how we do work with the public. Remember, it's got to be subject to informed consent. This is not, we're going to tell you must be screened for anything. But I mean, if you look at the uptake of aortic aneurysm screening in men age 65, it's actually at 80% of the public do take that up. If you make the test simpler, it'll also increase uptake. So in bowel screening, when we changed from the so-called fecal occult blood test, which required repeat samples, which people found messy, like leaving it around their bathroom, and it went to a single fit test, actually the uptake leapt up by about 10%. So make it simple, but also then we've got to work with certain groups where I think the knowledge and awareness of the screening is less. We do need to work hard with them.
Good, Richard. Want to quickly?
Yeah, just pick up on one of the themes that around that Mike picks out on sort of consent, and that for us, I think the NHS Change Programme is a really key example of public engagement on the shift in general. That includes a shift in how our data is used and held, and we need to do that. And I commend the programme for being really proactive on that and including that as a headline piece. We found with our work, which always data's at the heart of it, engagement before we design programs, and actually our newborn genomics program, a really big component of it is engagement about people's attitudes to it, both on the acceptability of joining a program, but also looking to the future and saying, what would the models be that you're comfortable with? Because this is about making a shift, and I think we need to be really on the front foot about explaining why this shift is necessary, and they all come together. You can't get the shift to prevention without accepting the shift to digital. And that comes with the acceptance of the use of your data in ways that will support better care for all of us. So I think that piece is a really important piece for public engagement, the shaping of it. It's not just about, you actually said, how do we influence the public? It's about the public also influencing and helping design the system.
And just coming on a very basic level, you just pay GPs to get a 90% screening. That we go round, we make sure they come in. And it is quite an effective way of doing it. Sorry, being very base about this, but it does work. So yes, come in.
Hi, my name is Zara Shah. I'm an AI and frontier technology expert. I sit on the ICO's technology panel, as well as serving on a few other private and third sector boards. My question to this panel is, you're UK's top experts in the healthcare sector. And I would like to know your view when the UK actually develops its own AI regulation, which it will need to do in the future, what key areas must it consider for the healthcare sector to mitigate the key risks in your sector to ensure that we come up with regulation that is fair, balanced, innovation-friendly, and serves the greater public good? It protects the people of the UK. What areas should we consider?
Great, thank you. Good question. Anyone particularly want to take that?
So I have a go at that. One of the things we really need to know is, does it work in all parts of the population? So going back to the idea of looking at a skin lesion, if you've got different types of skin colour and skin texture, does it work equally well across those? Do we know whether, even with breast screening in AI, does it work for the whole population? Does it work better in certain ethnic groups than others? Those are questions that we are wanting to answer, which is why studies of AI need to be in large populations and representative populations.
So evidence-based, that's what we mean.
Sorry,
It needs to be evidence-based.
Right.
I mean, that's what you're saying.
Yeah, but across the population, not just in certain sections of the population.
It has to be shown to work. So, Richard, would you like to comment as well?
So from our perspective, I think it's a really good question because I think that there's some very general principles around AI. There's also some exceptionalism where I'd say actually largely the evidence needs to be at a bar that you would apply to other things too. And then I think with different uses, one needs to ask exactly your question. Within the genomics area, we have sort of two particular areas we'd highlight. One is actually the equity piece that Mike's already picked up on, and I think that's crucial in lots of areas of healthcare. It's one we're particularly focused on. The other area is actually identifiability of data so sometimes when algorithms, particularly say large models, are trained on large data sets, we need to be clear that when that model is taken away, people don't become identifiable within the data that's held in the model. That's something that we need to be clear on the standards, be clear on the expectations, so that we can deploy this at scale. But that's one example that's quite genomics specific. That I think there are a number of in different areas. And again, I think we're in a potentially really positive position to be on the front foot here, because this isn't a problem that's unique to the UK, but it's one where if we get that in place, we'll become a really good place to test, prove, and if they work, roll out these technologies.
Yeah, I mean, I might add that there's also a real feel of stepping into the unknown. And I had a conversation with the chap from Google DeepMind a couple of years ago, and he gave a really good anecdote of an old computer game that had a ball bouncing around, knocking out bricks and bouncing off a bat at the bottom. And they set up an AI system to learn the game. So it didn't know it had to move the thing at the bottom to knock the bricks out. But actually, left long enough, it worked out that the score thing was the thing to do, to get it ticking over, and it wanted to knock the bricks out. And actually, they were impressed by the speed at which it learned the rules of the game and how it was able to adapt and quite quickly be faster and better than a human. But what they didn't expect, that it would find a little caveat in the coding which allowed it to cheat. And the ball could bounce around the sides in a bit of the hidden part of the screen that you couldn't see, get the ball up the top, and it would roll around knocking the blocks out forever. And it's that, I think we're still learning how to control AI technology, and we have to be really careful in drawing regulations up that when we don't really know quite where it's going to go. And I think using it in very specific cases where it's a tool that aids humans making diagnostics is the way to go. In careful slow steps, which I know is probably not what everybody wants to hear in the room, but that's my personal opinion on this.
I agree with that. There was a question over there was there a gentleman? Yeah, that's right. Do you want to take that? I'm trying to pick everyone. I do apologise if I'm not seeing you. So we'd like to say your name and your...
Thank you. My name's Andrew Doctoretta. I'm an intensive care consultant just over the road. I've got a particular interest in sepsis and immune inflammation and diagnostics. And I wanted to make two pleas, if that's possible. One, the NHS is still amazing and does amazing work. Professor Powis mentioned the spirit of COVID. And in COVID, we adopted a technology called metagenomics, which is on the sickest patients who we bring back on ECMO. We can diagnose their respiratory pathogen infection in 12 hours. It is utterly transformative. It's everything diagnostics should be: diagnostic enrichment, prognostic enrichment. We get a better treatment to our patients faster. They get turned around quicker. My plea is I think the threshold for studies, for diagnostic studies that aren't intervention studies, should try and just turn the thermostat down a little bit and lower the threshold to enable them. My research in activation of the immune system in my own hospital, it's taken me 2.5 years to get a study, which is essentially going to fail. In the same time, I've been able to do 3 studies, one in the US, one in the Netherlands, and one in Germany. And mainly that's bureaucracy. I'm an insider. I know all the levers to pull, and it's that bureaucracy that's killing studies. And it's just a plea, particularly for diagnosis, to just turn that regulation and dial down. I've had to recommend 2 companies take their trials outside of the UK because of the bureaucracy. The minister spoke earlier. This technology is incredibly powerful. Prevention is better than cure. That's a just standard thing we all learn at medical school. And it's really a challenge for all of us to learn from COVID, remove as many of the artificial barriers we put in place as possible. Thank you.
Okay, thank you. Another challenge.
I absolutely share your pain. We've got studies that we can't do because research and R&D approvals, but particularly information governance and data sharing. And particularly data sharing in the NHS. We are all in the NHS, but if I want to share data with another trust, I have to get a DPIA, a data sharing agreement, and you name it. And it's a complete and utter nightmare. And Stephen, if you could do anything to help with that, it will be absolutely fantastic.
Yeah, could I have Peter there? So Peter in the front row, sorry. Peter is actually an ENT consultant, but recently became an MP like myself. So.
Yes, I'm a less predicted NP than Simon, however. So this is a meeting in Parliament, and we have some MPs here. And my question to the panel is, what would you like the Parliament to do to make the situation better? We've been listening here to all sorts of bright ideas. As Simon says, politics is quite slow, but we've got a lot of politicians here who are in a hurry to improve things. And I think that they would be very receptive to some straightforward advice about how you might improve the situation for our patients. Thank you.
Can we ask you, can we just go, has anyone like to take that one? What do you want us to do is the question. Helen.
So I'll start. Regulatory flexibility and removal of layers of red tape. Is it still needed? Why was it created? Does it do a job? If it doesn't, then make sure that it can just step through the system. And it's the regulatory flexibility and data sharing. Simplify agreements. We mentioned the data sharing agreements, IP agreements.
Is that MHRA as well? Because we're debating that, I think, on Thursday. Is that another?
Whatever you can simplify and keep safe.
Do
Do.
consent.
Lynn, yeah.
Yeah, well, simplify the consent processes.
Yeah.
And think about what the public want. So in terms of privacy and data sharing, because our experience is that people my age might be a bit more conservative, but the younger generation, the work we're doing with them, they want their genome sequenced and out there and all the rest of it. So I think we need to engage more with the public for that and help get that to inform our information governance and data sharing agreements as well.
That's good. Excellent. Thank you.
We've got a 10-year plan coming up. You, as parliamentarians, should influence it, particularly with what we've heard about the delays, the bureaucracy. It's in your hands to influence your ministerial colleagues so that you make sure that is tackled in the 10-year plan.
I tend to agree that GDPR is a real break. I mean, sometimes you're trying to do something with the hospital from primary care and they go, I'm sorry, we can't tell you anything. For God's sake, it's a patient, isn't it? And the patient can't believe that you haven't got the same computer system. So, that's definitely true. So, Richard, do you want to say?
I think the theme's set for the 10-year plan, the shift to digital, and with that, therefore, protection of investment in digital infrastructure that's necessary to support it. Investment in the sorts of programs that can look and demonstrate where prevention does and doesn't represent value for money, and so that digital infrastructure again to support the shift to the community, I think, is crucial. So I very much condone that. I would also pick out an example of the sort of intervention that's already been really useful in the new government in terms of the data shift, which is the Secretary of State's support for the use of GP data for consented research studies, including our own. And that's a really good example where a political intervention can support really sensible flow of data that people have consented to. And I'd really condone and support that sort of intervention.
Yeah, that's absolutely true. I'll go to Lynn and then to you, Stuart.
With my BRC hat on, I just ask that you continue the support for the NIHR and funding for the NIHR, because that allows us infrastructure which maintains the research, and it actually has done an awful lot in terms of implementing new services. Nodding heads. So I would put a plea for please maintain that.
Yeah, and I would answer Richard as well. This whole sort of protection of data, we can easily anonymise it. It's such rich data we have. And one of the things that they found, I spoke to a Swiss doctor in COVID, and he said, I tell you what, you NHS, you've got amazing data about everything, but we don't really use it, do we? So that's absolutely a good challenge.
It's got worse since NHS Digital has moved into some other part. Getting data out of them now, or sharing the data, is like trying another example of pigs flying.
Absolutely, I agree with you. So, Stuart, would you like to come in?
Yeah,
What would you like to see?
I don't want to repeat things that Miss said. So one other thing I would like to add to the mix is transparency of the process. We've already had a comment in the room about I know what levers to pull. Well, we don't want that. We want the average Joe in trust with good ideas having clear frameworks and pathways available to them at ground level and not at higher level. So I'd like to see that transparency of process being available to all.
Yeah, I think that's great. Well, look, I'm afraid that's all we've got time for now. But as I say, we will have this room for another 3/4 of an hour or so. Can I just say thank you, first of all, to all the panels? So can we show our